I have the very distinct privilege of moderating today's session. I'm going to stay, for the most part, pretty quiet and let Dr. Wallace have the mic. Dr. Lee Wallace is the lead of emergency and critical care at the World Health Organization headquarters in Geneva. Before taking up this post, he was the head of emergency medicine for the Western Cape government and professor and head of the Division of Emergency Medicine, both at UCT, the University of Cape Town, and Stellenbosch University in South Africa. In addition to that, which would be a distinguished enough CV, Lee is the past president of the International Federation for Emergency Medicine, IFEM. He's the founder and president of AFEM, the African Federation for Emergency Medicine. He's the editor-in-chief of the African Journal of Emergency Medicine and has authored too many book chapters and journal articles to name here. Would be here, and I'd use all of his time if I started to name them. He's the editor of the Oxford University Press AFEM Handbook of Acute and Emergency Care, which, if you don't have your hands on, is a fabulous publication that I think everybody should have on their shelf. And without further ado, I'm going to turn it over to Dr. Wallace, who's going to be talking to us today about some of the fabulous things that the WHO is doing in emergency and acute care.
Thank you, Amelia. I introduce myself. I sound like I'm an ass, so thank you for doing that. It's good to start. There's lots of familiar faces on the screen. It's great to see so many of you. It's like a few new people and old friends. So it's nice to be connecting with you. Let me share my screen and see if it's working. You got my screen? Okay. It's a while since I accepted this talk. It got rescheduled, I think, from December. So if you need me to limit to be like 20 minutes or something, just tell me. I have a bunch of slides. I can be as slow or quick going through them as you need. But I just was going to run through our approach to, yes, centered on emergency care, but more widely, this new integrated approach to talk about eco. You know this. I'm not going to dwell on this. We're going to eventually get around to relabeling this, but the emergency care system framework is the same system framework for critical care and surgery and anesthesia. You get something that happens in the community at the scene, something needs to happen during transport, and then things should happen to you in the hospital. The only difference really between this and critical care is you'll see in the top right-hand corner, we haven't really fleshed out what happens in the critical care unit or the operating theatre when we develop this, but we have done all of that work now. It drives all of our programs. Beyond the fact that we understand what the system is like and we try and support across it, we are driven by a couple of more global issues. We're driven by the burden of disease. I'm sure you all know these papers. So DCP, the modeling study in DCP3, showing that over half of deaths in low middle income countries and over a third of disability from conditions that emergency systems should be able to impact. And then Junaid Razak's paper and Chan's paper both confirming that somewhere between 50 and 60%. And the lower income the country is, the higher the percentage of patients who die each year who are from conditions that are amenable to emergency care. I'm sure you all know as well that there's a bunch of resolutions in the past. I'm not going to dwell on these, but many of you have been working with us either through AFEM or IFEM or WHO over the years since the emergency care systems one came out in 2019. But of course, we got derailed by COVID, and I'll come to something more exciting than 7216 in a second. The Sustainable Development Goals clearly is one of our big drives as well. We work for the ministries of health, and they are driven, governments in LMICs are mostly driven by trying to achieve the SDGs. And therefore, our work is driven by the SDGs and the targets in the SDGs. But as our Director General just announced last week at World Health Assembly, it's not looking good for one of those SDG targets, which is to achieve universal health coverage with a 2030 target. Right now, over half the global population lack coverage to what you might deem to be essential health services, and 357 million out of those 2 billion people who suffer financial hardship, 357 million of them were bankrupt by healthcare, which is clearly an unacceptable situation that we need to try and improve. That's some background, just thinking about why we take the approach to integration that we do. Just to say that how you organize your health system in a country, it establishes a pathway. So where you put primary care, what happens in the community, where you put primary care and what services are available, what you put at the first level hospital, where those hospitals are, where your referral hospitals are, and what services are available. It makes a pathway. And that pathway makes channels and movements that go across the system, up and down the system, referral and counter-referral. And sometimes it works well, and sometimes it does not work well. And it's all about how you design it and how you take the needs of patients into account when you're designing it. Because when the pathway that you design doesn't match what patients need, they will make their own pathways. And often that has a significant cost to this system or to the patient. So this is a good illustration because I'm sure, I don't know if you're all emergency medicine, but this looks like an emergency department when the primary care system is failing, for instance. And the primary care system might fail because patients don't have confidence in it. And that's usually a reflection of underinvestment and a prioritization of it, which is a planning and pathway issue. Or it might be that the services are unavailable. So many parts of the world, primary care is available Monday to Friday, 8 till 4. So if you design the system like that, patients will find their own way. And unfortunately for you, this audience, that is usually through the emergency department with things that they don't want to be there for. They don't want that long wait, and you don't want them there. And it burns you out, and you get fed up of seeing primary care type patients, and both patients and the system suffer. And of course, it's much more expensive to provide primary care in a hospital, for example, than in a primary care. So with the idea of pathways in mind and thinking about patients don't experience emergency care and then critical care and then operative care and then back to critical care. They just have, the patient has a journey. They get sick, they get to a clinic, they get an ambulance, they get to a hospital, they discharge from the hospital. Things happen to them in the hospital, but they don't verticalize. If I don't wave my hands in this WHO office, all the lights go off. So we're trying to save the climate. So it will go dark every now and then, sorry. So patients don't verticalize their journey. So we're trying to really engage with partners to stop verticalizing. So we're talking about a continuum from the community, through clinics, through hospitals, and back to the community. So linking in things like effective rehabilitation and other ongoing care needs beyond the normal sort of acute care components. And with all of that in mind, last year at World Health Assembly, we moved from the 7216, which was the emergency care system resolution that really got derailed by COVID, to recognizing that beyond the work that needed doing on emergency care systems, COVID had identified that actually, if you don't have emergency and critical and surgery and anesthesia services right on a day-to-day basis, you cannot respond in a pandemic. That allowed us, that visibility that COVID brought allowed us to say, and by the way, we already knew this, you can't respond in an earthquake and you can't respond in a conflict. So we got this resolution that links ECO both to universal health coverage, it's the day-to-day system, and to large-scale health emergencies, whether it's man-made or natural. Our unit came around just before COVID as well, after the resolution had passed, but before COVID kicked off, November 2019, actually. So we only really started to be able to do our work. Much of the world ended COVID about a year and a half before WHO officially did. So we've only really been working as a properly constituted unit for about 18 months now. And these are the things that we cover. And just to be clear, it's not a big team. There's Terry Reynolds, who I'm sure many of you know, myself, Emily Calvello-Hines, who used to be at Colorado, Vanessa Naidu, who used to be with me in South Africa, and then John Fogarty, who's our primary care lead. And that's it, there's 5 of us. So we help governments with models of care, like what they should put where in the health system and how they should design the system, how patients should move up and down across the system, so referral, what should be available at different levels. So when you get to primary care, for instance, what emergency care should be available, what care for diabetic patients should be available, because that then drives what medicines should be available and the equipment and the training that the staff need, and therefore the level of staff that you need at different levels. Your service package really is central to how your system works. We're responsible as a unit for the role of hospitals in the health system, and then a lot of clinical care guidance and tools and learning programs. And I'll come back to those a little bit. This is sort of, before I get into a little bit of detail on each of them, this is, I should have said at the start, there's a lot of information. You can have the slides. You're welcome to just reach out to me and ask for more information about any of these. And Hopkins is a collaborating center. If any of you want to do some work with us, you're very easy to link in through the collaborating center, of which Amelia's a staff member. So a very easy mechanism to work with you now through this formal relationship. So we have a bunch of clinical process tools. A pre-hospital toolkit, for instance, coming out shortly. That's like 10 different things, from training programs to clinical protocols through how to actually run your pre-hospital service. Facility-based care tools, a lot of things either in existence or about to launch soon on clinical quality improvement, lots and lots of training courses, then assessment tools, advocacy tools, and tools to support implementation in country. So we've been busy. We had a lot of money during COVID, and so we had a lot of consultants who got a lot of these things started. And then since all the money went, and it's only the 5 of us, we getting these over the finish line slowly. So if you look on our website, for instance, you won't see many of these. You'll see reference to them. But if you wanted to learn about any of them, you just shout me. I can share things with you. Just to remind everyone, again, it's the same system. So all of the stuff that we're doing to allow people to provide care on a day-to-day basis is absolutely the foundation under which they provide care when crisis happens. So our approach, excuse me, to this eco-integrated pathway really falls into 3 broad buckets. That slide I just showed you with all of the hundreds of tools on it, they fall into 3 main areas. We support ministries with how they plan their packages and what the system looks like. We support with technical guidance on how patients should be able to flow through the system. And then we have a lot of focus on improving the actual care that's delivered at the sharp end when you interact with a patient. Just to point out, all of these have got QR codes on them to help you navigate to things on our site. The Speedy package has been used in about 60 countries now, including like in Gaza. So we have a humanitarian component of it. When you go into it, let's say here, you're looking for what should be available for treatment of injury. And it's from sort of injury prevention through to specific intervention. So here we're going to see laparotomy. So you go down to the actual intervention that you want, and it tells you what level of care you need, what medications you need. The medications links out to the essential medicines list, so you can get all the information about it. Tells you what equipment you need. And on the right-hand side, those gray and green circles, that's active decisions made by the ministry. So where do I provide laparotomy in my system? And I know it's not that easy to see in the top right. The 2 green dots show that the first level hospital and the second level hospital is where laparotomy is provided. So clearly it's not provided in primary care, but they usually have community, outpatient, primary care, and then first level and second level hospitals. So then you can look at this, and wherever there's green dots, say, okay, this is provided, this intervention is provided at this level of the health system. So it allows then, with an export, it allows the country to work out exactly what's available where, and then you can cost it and so on. We have similar planning tools about the pathway to care. So not just the things that are available, let's say, in the hospital for management of trauma, but how you make decisions about when patients go to a primary care facility or when they go to a first level facility, how you decide to refer from one to the other. And more importantly with this, it's called a C3R tool, Core Clinical Care Readiness. This allows you to assess where the gaps are. So you plan out what your system should look like, you plan out how and when people should move, And this tool allows ministries to identify at a local level what the blockages are, why it isn't working well. We don't have protocols, we don't have human resources that are trained, and so on and so on. So it'll give them a set of interventions when they do this sort of assessment of the pathway, which can be done at a local level in a city. It can be done like a provincial level. It can be done at a national level. It's just less, it loses accuracy. The intention is that it's more local system planning, meso planning. But they come out to say, look, we have a problem. We can only partly do initial assessment and resuscitation, and that's because we can't really resuscitate critically ill patients. Here's some things that you can do. You can establish protocols, you can provide BEC training, you can do advanced emergency care, you can put some customizable actions, and you just select those, and that will give you then an implementation roadmap to improve your system. So you end up with this sort of list of things that you need to do, and then you can cost it. And so you know not only what you need to implement, but how much it will cost you as well. Moving away from the planning, much more to patient interaction, we've launching a series of things around referral and transfer, starting with referral forms, transfer checklists, handover tools, things that are where we focus is gaps that are commonly identified in countries where there are weak points in the system. So we know, for instance, that the quality of care at first level hospitals often isn't where it needs to be, and patients need to be referred to a high level care. But we also know that when they get that transfer, there's almost no care, or the care is way worse than it was at the first level hospital. And then they turn up at the referral hospital and nobody knows anything about them, and there's no information transfer. It's a risk to quality, it's a risk to patient safety, and so on. So these tools help to direct the referral that's made in the first place and the actual transfer to make sure that there's adequate equipment and trained staff in the ambulance and so on. Then when we get into the things that we do around learning programs, for one, we bundle all of these from the left to the right: primary care, emergency care, critical care, and operative care. We're calling them all this impact course and trying to have a common theme throughout them. So starting in the community, for instance, we have a first aid training program, and that first aid is really not our thing. IFRC do that incredibly well through their National Red Cross organizations. But what they don't do is link you into the system. And we know that if you link community first aiders into the ambulance system, you can have a massive impact on trauma. There's some good data from a couple of systems around the world showing 20 to 40% mortality impact. So we've gone for this exactly the same. I'm sure most of you on the call know the basic emergency care course. We've taken the same approach in CFAR. All of our courses really center on the same BEC approach, the same methodology. So you get not only integration across ECO, but we have integration across our learning programs and all of our technical products as well. They all use the same images, for instance, the same illustrations. So this is an example of a skill card that you would get, and you'll see it's got IFRC's logo on it as well. So we co-brand wherever possible to really amplify the impact of our products. Ambulances usually have either a basic medic or an advanced medic when you do like a professionalized service. Of course, in many places they're run by hospitals with whichever nurse happens to be on duty that day. But as we try and encourage them to move towards trained medics, we've started with the basic because most of our efforts, as you'll see, are getting the basics right before going into more advanced stuff. We'll eventually work on our advanced ambulance provider course, but we've got this 4-week basic ambulance provider course, and then we have a bunch of protocols, currently 25 clinical protocols that the basic providers can use to deliver care in the field. And then the BEC course. What you probably don't know is that what was for years a terrible, very limited website has bloomed into this. There's I think we have about 10 websites now with all sorts of new videos. We've got videos from Afghanistan of BEC. We've got Zambian BEC videos with all sorts of resources. And I would encourage you to go look around our websites and you don't just get this rush through from me. You can actually look at our tools in more detail. The BEC course is central to, as I said, our approach to educational product. And it is traditionally a 5-day in-person course, but as of October, we'll be launching the flagship project that we've done with the French government, BEC Academy. So there's a building in Lyon in France that will house the academy, like state-of-the-art educational center, but not easy to get to for most people. Who the other big part of the academy is the online platform. BEC is one of the first courses to launch on there. So we have these videos. One of my old registrars from Cape Town, Dr. Toomey, narrates a lot of so she's either live on video or she's been made into like an avatar and takes you through the course. And you'll see the style of the illustrations is completely consistent with what's in the BEC manual. So you learn all of the content online, and then you do a 2-day face-to-face practicum. So we've just been piloting this. So a couple of things with this. First of all, it keeps people closer to their workplace, which is great. Secondly, we've got a lot of financial and other support from Laerdal Foundation around this, which we're very grateful for. But probably most importantly from that, these mannequins, although they're basic and they're cheaper than you'd probably go at Hopkins, they're still in the thousands of dollars range to run a BEC course. With Laerdal supports, understating it really, Laerdal have led on it. They've made now a mannequin kit in a backpack that weighs less than 6 kilos and provides all of the... Rachel's bringing cupcakes because I look sad. Thank you, Rachel. I'm having cupcakes delivered. Look at that. You're a superstar. Thank you. So thanks, Rachel. Have a nice evening. It's all of the mannequins are sort of stacked, and it allows you to run a skill station. It's less than 6 kilos, but way more importantly than the weight, it's less than $300, and it allows you to do the airway. It also has CPR, which obviously isn't in BEC, but it allows you to do wound management, everything, all of the skill stations. So if you have 5 of those kits, you can run 5 skill stations at the same time. But even with one kit, you can run a course of 12 people. And Laerdal are donating about 1,000 of those, but the intention is that they're affordable enough that not only do you come and do the course and go home with better knowledge and skills, but much more importantly, you take the kit back to your hospital and you can do high-frequency, low-dose training, which we know is what's impactful. The Laerdal Helping Babies Breathe program with WHO, as they're about to release I think their results are pre-published right now, but they showed that if you do the HBB program, they have something like 40% mortality impact on perinatal mortality. But if you have this high-frequency, low-dose training, it goes up to something like 75% mortality reduction. So we are copying that directly into our approach to BEC and then ultimately our other programs as well. We're building from BEC the trauma content to do some more like advanced airway procedures, chest tube, intraosseous needle, things like that for an advanced trauma procedures course. That's nearly done. And then with support of the Wellcome Trust and with these partners, we, BEC was with International Committee of Red Cross and with IFM. So the basic critical care, BCC, is with these partners. BCC takes exactly the same approach as BEC, and it starts from our entry point into basic critical care is you must have the skills and knowledge that's in BEC. I'm not entirely sure how we enforce that, but we're saying, if you can't learn how to open the airway and do bag valve mask on this course. But equally, given where the gaps were in COVID, we stayed away from our pre-COVID idea, which was to do an intensive care course. And we went for a very basic critical care course, taking the same trauma, difficulty breathing, shock, and altered mental status approach. It gives a deeper dive into the conditions, and we get like a medical algorithm to manage asthma, COPD, for instance. But it's much more about recognition, frequent monitoring, safe handover. This is really for patients who have had BEC management and are still in your emergency unit, or they are sick in the ward, or they're in a critical care unit. But we're not aiming at the intensive care crowd. We're aiming at that gap between what happens when you arrive at the emergency unit and when you're in the intensive care. So you'll learn how to prepare for intubation. Then intubation is an optional module, but it is not in the core course. So this was our second pilot, which was in Belize recently, and the course is going up on the Academy now, and that's the teaching card that goes with the CPAPs. Any of you who have taught BEC until very, very recently, you get the course and you get the book and the slides, and you're kind of on your own to teach it. We've spent a lot of time standing up very didactic materials because we see a lot of variation in quality of teaching, and not only quality, but also interpretation of what should be taught. Some people teach different procedures, different ways. So we've stood up lots and lots of skills cards and these practical skills training, pracs, so that you can get a lot of simulation training, which has not traditionally been part of BEC. I used to really enjoy my job in Western Cape and doing emergency care. And I came here as lead for emergency care, then found I was lead for emergency and critical care. And now, since we no longer have an operative care lead, I'm also lead for surgery and anesthesia. So I spend a lot of my time with surgeons and anesthetists, including last week at World Health Assembly, speaking in 9 surgical side events about how amazing surgery is. But we had, from about 20 years ago, we had 2 books, surgical care at the district hospital and anesthesia care at the district hospital, which are the sort of staple of surgery provision in district hospitals across low-income countries particularly. They have been bundled into 7 modules. We're almost done with the first 4 of them, and they'll come out on the Academy also. So we'll be able to take someone from the roadside, like a community first aid response, through an ambulance, basic ambulance provider, and the ambulance toolkit, through the emergency unit with our tools like the trauma care checklist, resuscitation algorithms that we have, big posters, the BEC approach, and then the trauma course. And then you'll be able to take them to theatre and into critical care also. So really expanding the eco approach. We have a whole bunch of stuff around primary care as well, which I'm well aware already. I'm completely overloading your brains with information. I've stayed away from the primary care stuff. I had agreed this with Bacti before. There's no way to do this. There isn't just an absolute fire hose of information, because I'm sure you probably know 5% of this already. We've been really busy and there's a lot going on, and you need to know about it so that you can go out and start to advocate to use it. So on that, if you talk about injury, we have the triage tool, we have the trauma care checklist, which has been around, and we know that has a 50% mortality impact when it's used. We have the safe surgery checklist, which has something like a 90% reduction in surgical errors. We have kits like the trauma and emergency surgical kit, which is when a conflict happens or an earthquake happens, it's what we deploy to support hospitals to provide care. So beyond the training programs, we have a lot of other activities. Also have for emergency units a mass casualty management program, also on the Academy. Also our area of responsibility, and we have this simulation center in Lyon as part of the Academy, which is mocked up as an emergency unit, and we run mass casualty drills through there. If any of you want to get to be an instructor on any of these, it's really worthwhile, because we can, it's not like 5 years ago becoming a BEC instructor where it was great and very impactful and makes a difference to patient outcomes, but kind of the educational approach was great for the participant manual and the slides. So no one had ever had the bandwidth to really focus on how it was taught. And we've really done a lot on that. Emily on our team, and then Melissa, one of our consultants who's based out of Mexico City, have taken the lead on that. Have been amazing. So on the back of all of the stuff that we've done, we keep getting a lot of demand for conflict-related stuff. So CFAR has a version that is conflict-related, here being taught in Iraq. But more interestingly, I think this is OpenWHO, which is one of our other online platforms. It's really voiced over PowerPoints, but we did an extension of BEC for blast, gunshot, and burn. And in 8 months, we've had something like 20,000 people take this course. In the years that BEC has been running in person, we've had about 20,000 people take that. huge demand for this, and also huge demand for online platforms. I think some of you know from the past that we had a trauma registry at ERTech, it was called, when it first came out. But we've now expanded that, also integrated. So we're about to launch a primary care module. We have an emergency care module, trauma care, and we just last week announced and sort of officially publicly launched the surgical or operative care module. And we're working with a couple of the critical care societies to develop a critical care module and a sepsis module. So whichever part of acute care you're interested in, there'll be a registry module, which is free. We house it. You just need data entry and like an Android or a laptop to enter the data on. And I can tell you in detail about that, but it's a really powerful tool for quality improvement. Blah, 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 blah. Why are we doing all of this? I told you there's a burden of disease. We've got also a mandate from resolutions, and we have a mandate from the SDGs. But what actually happens, because we're producing all of this stuff, and we've got to know that some sort of impact happens. So we know already from Disease Control Priorities 3, DCP 3, that pre-hospital care is super cost effective. And I'm not going to tell you about that left-hand picture. But Kaylin Werner, who's a AFM intern and then PhD student, she did a PhD while she was in Cape Town and looked at cost effectiveness of the WHO Emergency Care Toolkit in Uganda and saw a 655% return on investments. Do this partly because it's highly cost effective. It's not an expensive part of the system at all. But more importantly, we just studied, way back in 16, 17, we'd studied a couple of thousand patients in Uganda and Tanzania with those conditions on the right-hand side going into hospital, and we looked at 48-hour mortality, and we got a really impressive mortality reduction. So we got a lot of money from a funder, which was great of them, AO Foundation. And at 17 hospitals over with 6 to 12 months pre-implementation data and 6 to 12 months post-implementation data, we studied 37,000 patients, and a consistent, from site to site, condition to condition, age group to age group, 50% mortality reduction. And these are interventions that are the basic emergency care course, the triage tool that you can see on the picture, the trauma and emergency checklist. They're bits of paper. So the cost per hospital was about $3,000 to $4,000. And for that, we see a 50% in-hospital mortality reduction. So in both cost-effective and incredibly clinically effective. So that's why we still are here as a team, and it's why we believe that we should be really rolling these tools out, and why we want our partners to help. And you can find out more about the unit overall on our unit page, or about ECO on our ECO page, about the toolkit. We have dedicated tools. We're standing up right now a page for clinical management of trauma as well. And then we have this initiative right now where we're trying to get, of the 20,000 people who've taken BEC, only about 20% of them are nurses. So we're trying to get nurses and midwives, first contact nurses, into BEC. And we've got this 25 country campaign running right now where by the end of 2025, we want to really ramp up access to BEC training. And I know Jhpiego has really been supporting us with that. I met the chief nurse of Jhpiego last week. You know, Bhakti had been quite active in getting Jhpiego support. And some of the countries where Jhpiego is very interested in BEC training are the same countries. So transitioning those countries from just training the doctors to really focusing on training nurses. All of which leads up to, given that we had a resolution a year ago, on the back of such overwhelming support for the resolution, we kept getting asked, can you do something? It might not mean much to you. I don't know how well versed you are in like global health policy. One of the most powerful things you can do, apart from have a resolution in front of 194 member states in this room, which is Committee A down at the United Nations Palais. One of the most powerful things you can do is have a global strategy and action plan. So that is, it takes about 18 months to develop. It is signed off by the Assembly, and it becomes a 10-year, it's the instruction manual for both WHO and countries for 10 years, We just got that passed unanimously last week. So by sort of this time next year, we need to have stopped our consultation, and then we have a few months to write it up. And then by the end of the year, this needs to be in the approval process so that by May, this will get approved in 2026 at Assembly. I know that sounds slow, but what will happen in the meantime is round after round after round of both WHO consultation across all of our levels and country consultation and clinician consultation, so professional societies. So we'll be attacking conferences and large meetings and what have you, and get in clinicians' inputs into what should be in here, while at the same time undertaking large studies to gather some data, like what's the reality of eco at the moment, and developing indicators like how should you measure the health system's integration of care? How should you measure how effectively operative care is being produced? So, there's the Lancet Commission on Global Surgery that says you should have an indicator like access to surgery within 2 hours. So we'll be having indicators like that, and that it will change the global landscape. Like it's not hyperbole to say. I spent most of my career knocking on doors trying to get $5,000 and trying to get people to listen to emergency care. It is now literally like a fire hose. Every time you step into this office, it is just outrageous the amount of demand there is for this eco, both because of COVID, but also because of the state of the world right now and where it's going. People recognize that if you don't have this part of your system right, it's not going to function. Everything else that you do will just crumble as the climate gets worse, or as conflict spreads, or refugees, or all of the multiple crises we've got. But this is central in both the universal health coverage agenda and in the World Health Emergencies agenda. And it's going to be incredibly powerful going forward. To effect it, with a team of 5, we can't do it, so we need partners. So Hopkins Collaborating Centre's already got an application in to be part of the Acute Care Action Network, but this is our main strategic response to the resolution while we develop the action plan. This is how we convene all of our partners together around primary care, but also eco, both funders and multilateral agencies, organizations like MSF and what have you, but also collaborating centers, professional societies, non-state actors, what have you. So ACAN is fairly newly developed. We're supported strongly by and financially by both Laerdal Foundation and the American Heart Association. And if you belong to an organization that is doing acute care internationally, globally, regionally, then if it's not already applied to be part of ACAN, please, we want as many partners as possible in ACAN, because we're not going to be able to implement the stuff just sitting in the office here. Priorities have been identified for ACAN at an Utstein meeting. This is the path to the Utstein Abbey in southern Norway. So the emergency care toolkit is one of the priorities: work with communities, work on service design, quality improvement, and then strategic planning. So we're really leaning into the toolkit rollout, because since we got these priorities last September, we've got this 50% mortality impact. So we're really after funders right now to try and support rollout of BEC through multiple different forum. I'm sorry, I told you it was going to be a lot. It's a lot. I'll stop sharing and back over to you, Amelia. And if anyone can actually think right now, I'm happy to take any questions.
I'll leave the mic in your hand a little bit longer, Dr. Wallace, because I anticipate that there will probably be some questions. And just reaffirming what's been said, the talk is recorded. We are happy to share the recording. Dr. Wallace has given us generous permission to share slides as well. This is an extraordinary body of work that reflects the sweat equity of a number of years. And a lot of extraordinarily talented people working on making materials that don't cost a lot, but do a heavy lift in terms of helping make sure that every day, every place that emergencies are happening, people have the tools and cognitive structures that they need to do their best work. I see we have a question from Dr. Gutierrez. Please go ahead. You are still muted, I'm afraid.
Sorry, I think by now we've figured this out, right? Very nice to be here. Lee, thank you so much for the great amount of information you just shared with us. I think you know where my question goes. It has to do with the development of acute and emergency care systems for critically ill injured children. I actually just published a paper. I didn't mean just to share it randomly in the chat, but I put it in the chat. Over the last few years, pediatric emergency medicine actually has developed in a fairly robust way globally, and entire regions have embraced PEM as the next natural step on acute care system developments. I wonder, Lee, from the WHO perspective, I know we look at indicators of under 5 mortality. I know that it's been built in the courses that are done, and there's something else in maternal and child and obstetrics part. But I don't know if there's anything really more focused on the acute care of injured children or ill children from that perspective. And the other part of the question is, how can we work together to develop more understanding of the specific needs for kids in these scenarios?
Thanks, Camilo. Nice to see you. And
yeah, sorry, I'm in my car.
We see you in your car, no problem. And thanks for dropping that paper in. I just opened it. I'll have a look at that. It's great. I was just at I wish I'd been in Cancun at the weekend, but I was just online at Cancun at the weekend for the World Federation of Pediatric Intensive and Critical Care WFPICS, and had the same discussion with them. So I think from our source, the sort of answer is we don't single out children. To all of the products, we say, here are special considerations for children when they apply. Otherwise, you kind of do the same, which I know people who focus on the care of children don't like that, and it's understandable. At the same time, though, we have a whole maternal child health department. There were 2 actually with the partnership with massive focus on MCH here. They have ETAT, they have IMCI, they have a whole, if you're talking about kind of perinatal, they have a whole army of products about that. And for the first time ever, they've, we didn't exist before, so fine, but they're renewing, for instance, IMPAC, which is alarmingly close to IMPACT, which is ours, but IMPAC is the bundle of sort of antenatal, perinatal, postnatal interventions for mother and newborn, and they're folding all of our guidance into that. We are helping them produce it, including like, when do you refer a patient who's having a obstetric emergency, and how do you safely refer them? They have adapted our referral and transfer paperwork for that. So we're completely integrating across departments in a way that never happened before. IMCI and ETAT will not get sucked and replaced by ours. What we did, every product we've got, like starting with BC, we have worked closely with the child health team to make sure that whatever's in ETAT and IMCI is replicated in our content. So we don't come up with new recommendations. We take their recommendations and put them in the same format and pictures and stuff that we use through the rest of our content. But IMCI and ETAT are completely embedded into basic emergency care, forward into the community and ambulance, and further into the hospital, into the critical care stuff. Long answer, Camilo, sorry, to sort of say we don't single out, but at the same time, we take complete leadership of the maternal child health department, and we make sure that we represent exactly what they want, which is pretty, it's robust and has been road tested for 30 years now, and we know it works.
Dr. Wallace, I'm going to toss the mic to Dr. Moretzky. Thanks so much, Dr. Gutierrez, for your fabulous question.
Hi, Lee. So good to see you.
Rachel!
This is amazing. I just want to congratulate you for just decades, all the team. You guys have been working on this for decades, and it's just beautiful to watch it come to a place where it's not only recognized but funded. I know there's still work to be done, but I just want to first congratulate you. The second thing I wanted to ask is, in terms of fellows, I know Sean's on the phone and there's other fellowship directors. What is the best way for us to help you and help our fellows kind of contribute to this process, if there's a formal process? And I know sometimes I'm rusty on these things, so I apologize.
Thanks, Rachel. It's so awesome to see you. And I was in Rwanda a couple of weeks ago with Seon, actually, but therefore WHO stuff. We drove past the hotel where you had us stay when we did your residency assessment all those years ago. I was thinking about you. Thank you for the praise, Rachel. You know, I'm representing the team here, and I'm not just representing the team of 5. As you said, I'm representing like half the people on this call have been deeply involved in this work. It is a huge pyramid beneath us. Like, sure, me, Terry, Emily, whatever, we're standing at the top of the pyramid now, being reflecting in the basking in the glory, or whatever the phrase is. But it's coming from the work of lots and lots of people over 20, 30 years. And because I was presenting, I wasn't seeing, but there's people like Sean on the call as well, and others. So that's awesome. I mean, it really is a gathering of the team who've been, like Sean was leading all of the pre-hospital work pre-COVID, and we've picked it up and kicked it round a bit and got it over the line, and then everyone will be, oh, Lee's put this thing out. But no, it's like Sean led that whole team and got it. Anyway, fellows, one of the fairly crappy things that's happened after COVID is the intern program got taken away, and then it came back in this new thing where we have to advertise and then we have to pay a stipend, which is fine because we were excluding LMIC people before because of affordability. But we advertised for an intern. We got nearly 600 applicants, and it took us 7 months to screen them and get them down to 150 to interview. And by that point, of course, anyone who's half decent's got a job somewhere else anyways. So we gave up on the internship. Fellows, we've just worked out that we can do this. There's 2 ways to do it. One is if a fellow has like 2 months and they wanted to be in Geneva and work with WHO like we used to do, we can do that as a sort of once-off if somehow the institution is willing to say they are having a sabbatical of some sort. Like they're. So it's not easy, but there is a much easier route, which is if someone wants to just kind of dip in and out of stuff through their fellowship. We just link them through one of the collaborating centers. So you may have a fellow at Columbia, but Columbia is not a collaborating center, but Hopkins is. If your fellow is willing to pretend to be Hopkins for the part where they're engaging with us, I say I work with Bhakti as the lead for the collaborating center. If Bhakti is giving me a fellow, I'm asking no questions. So we have a mechanism. We've kind of worked it out. And I'm in the office. I shouldn't be saying that too loud. But we have worked out a workaround, and it's through the collaborating centers. Bhakti can give us, like I am just saying to Bhakti, we'd like a fellow or 5 fellows, and where they come from, I don't want to know.
Amazing. No, thank you. And we can triangulate with Bhakti. And then my last little sort of funny question is there a place to find all of the resources, the papers on your slides? Because it would be a nice book for our fellows and students to read, just if it's all in one place.
What isn't published yet, because we just don't have the bandwidth, remarkably, is this what we think is like groundbreaking 50% mortality impact. We haven't got around to writing that up yet. But all the other stuff we have in a folder. I don't want to it's a lot of paper, so I don't want to email it to everyone, but I will happily share a link to someone if they could then just, I can put it in like Google Drive or something, share it to Bhakti, and then, and then they can share it more widely.
We can
So
certainly
I'll just announce that we are going to be launching a new website as a collaborating center called Open Acute Care, and it mirrors our partner website, which is Open Critical Care. And we'll be sharing information from all of the collaborating centers, but also of any of the other organizations that work in the space, and have a page dedicated to WHO resources. You can access them directly. The website's in development right now. I think the go date is mid-July, and it should be fully functional by September. And it's been funded by USAID. Thank you, USAID.
Awesome. Thanks, Bhakti. Was that what your hand up was?
I was just going to say one more thing is that this is the last ever sessions. What a really strong note to end on. Lee, I didn't realize how big the ask was when I made the ask, but there's just always more than I ever expect in these sessions. So thank you so much for joining us. The other thing was that a lot of you are graduating, and feel free to pop into the chat where you're going, because there's so many of us here that would love to see where you're headed off to next and what you're planning to do. when you come into like a new area or a new landscape, there's such a tendency to go in and fix it and just be like, oh yeah, I can make a checklist, or yes, I can definitely teach a lecture on that. But I'm hoping if you take one thing away, it's this. A lot of this stuff already exists. There's no need to reinvent the wheel, but rather like take the wheel, adapt it to the local context, train local individuals to cascade this further, right? And so just take a pause. And if you take a pause and you're like, I can't find it, email one of us, right? One of us will find the resource you're looking for and send it to you, because it's highly unlikely that something is not created. And if it hasn't been, then Lee will task you to create it anyway. So, it'll be a win-win. I also want to say thank you for showing up today. I've been on medical leave, so I know I've missed a couple of sessions, but this is the last session of this didactic series, and it's just been a real pleasure. Like I'm excited that we're not organizing any more of these, because it's a bit of work. But I'm really sad that I'm going to miss seeing like all of our friends who joined the sessions, and it's been really nice to connect with the other fellowship directors. So I hope no matter where everybody lands, that you find a way to like continue this type of community, because yes, there's so much happening and there's so much to do. But actually, we're a really small community, and our paths cross over and over again. I mean, Rachel and I have known each other now for like about 20 years, and Lee and I have worked together on and off for about 17 years. So again, teeny tiny community. So, yeah, I just wanted to say a couple of those things, but we will email out all of you when Open Acute Care launches.
As we said, any or all of us, the Collaborating Center here, are very happy to hear from you and connect you with resources. We'll share the resources from this talk very soon. We're going to stop the recording now. We would love to know from any of the fellows who are on the call where you're headed next.